replacement therapy, estrogen. We generally give hormone replacement therapy depending upon the requirement of the patient's symptomatology and things. But when these patients who require high thyroxine requirement, which itself increases the risk of osteoporosis, along with lower estrogen, so give hormone replacement therapy, of course calcium, vitamin D3 and all, which will help.
Is it must to prescribe calcium along with antithyroid drugs?
Calcium antithyroid.
Any thyroid hormone we are going to treat any patient, is it must to add calcium along with them?
That I think yes.
There is no role of giving calcium for patients with hypothyroidism to do anything separate. All human beings require between give or take 1000 to 1200 to 1500 milligrams of calcium. If milk is fortified, juice is fortified, you can get dietary calcium. Otherwise, you take supplement. So two things about the hypothyroid patient. So for those of you who prescribe, if you have a hypothyroid patient and you're going to prescribe them oral contraceptives, you're going to expect an increase in thyroid hormone requirement. Again, because of the estrogen part. It's very important to count. So again, I know Praba's scary. I mean, it sounds very scary, but you really don't get true neurocognitive deficiency. The whole thing is epidemiological look back, and it was like 7% around age 7 to 9.
Why we are telling so much about
No, because the moment you tell people get very scared.
It's not scary, but it's so important that you have to treat them at the right stage.
Right.
Because most of them, they come out, most of them, the older people, 40 நாள் ஆகட்டும் 50 நாள் ஆகட்டும் 3 மாசம் ஆகட்டும் அதுவும் முன்னாடி abortion ஆச்சு வச்சு ஒரு வாட்டி 50 நாள் abortion ஆயிடுச்சு உள்ள போகாத டாக்டர் 3 மாசம் கழிச்சு போ.
No, that's what
they're not taking folic acid.
When
they're losing the important period. How much to tell them?
So in patients who are hypothyroid, you have to counsel them that they should have
already
they should plan pregnancy.
Okay.
Plan pregnancy. In most of the world, pregnancy is never planned. It's very rare that people plan and have a baby.
Definitely.
So you have to tell them that they have to, at least in the part of the world we live where there's so much medical legal issues, we have to always document that we have spoken to a woman of childbearing age, that is anybody who menstruates. That you have talked to them at least once a year, every 6 months, whenever you want to see them, that they have to make sure the TSH is less than 3.0. And as soon as pregnancy is confirmed, if these are patients who have no thyroid gland and they have been surgically removed or ablated with radioactive ions, they're completely athyroid, to increase their dose by 30%. To do that is very simple. If they're taking 100 once a day, they take 100 6 days, and they take 200. They take an extra pill of the week. In people who have, so that's why I tell everybody, you to know what kind of hypothyroid they are. If they're very mild subclinical, they may not require such a high increase. Again, that's why in pregnancy, first trimester TSH target when you're treating hypothyroidism is 0.1, which is a hyperthyroid state, because you're trying to supplement. Same thing when you're treating a hyperthyroid woman who's already hyperthyroid, gets pregnant, the goal is to keep free T4 around 2, which is high, because it has to supplement, the mother has to supplement for the fetus. It's 18 weeks is where the cutoff is, where really you say that the fetus is now starting to produce his or her own thyroid hormone. But this neurocognitive did cause a lot of issue in the United States and worldwide, and it is actually retrospective data looking back, and it was around 5th grade, and that was at mathematical skills.
Congenital hypothyroidism, Lata will be able to tell, that is the most common thing which can be prevented. That's why they are talking so much about neonatal screening after 48 hours and then repeated after 2 weeks when the mother has hypothyroidism and all. Because that can be prevented.
So only we are talking so much any clinically diagnosed congenital hypothyroidism. We do a neonatal screening for all the newborns in most of the institutions. Have taken it up and they are doing it. It's not only neonatal thyroid screening, along with it they have other metabolic screening as well as 17-hydroxyprogesterone levels, because these are something which is preventable and we don't even have to wait for any clinical symptom at all. So that bigger institutions do have it. I think in United States they do for all neonates.
Here also, Lata, we are doing neonatal screening for all the
No, I'm talking about some of the private institutions they are not doing it, because we do see some.
So important.
The commonest
common thing they make out.
The commonest
they do a common test of metabolic disorders are very rare. Hypothyroidism.
See, we usually want
to treat it, because even later treatment still helps.
So pediatric dose is 2 micrograms per kilogram.
Yeah, but in neonatal requires a higher dose.
Even more.
Then we step it down. And the other thing is the presentation is that of a prolonged physiological jaundice. And the way we pick it up is because they are delivered elsewhere and they come to us for a follow-up around second or third week or the first time, and we find that still the jaundice is there. The first thing we do is to do an TSH level at least and start the medication, because we don't even want to delay anything beyond 6 weeks. Still there could be a problem, we start it early. The other thing is when they have a delayed passage of the meconium at birth, that's the other way we pick it up. These are the clinical thing, but let's not think about it. You have to do a neonatal screening, do a TSH levels, and make sure it is normal. And it's done usually at 72 hours, 48 to 72 hours, because of the surge which is there. The other question I want to ask is the adolescent period is again the common mistake everybody makes is about a pubertal goiter. They say it's physiological. Goiter at any age is never physiological. You have to evaluate. And as probably that's the area which I'm working, we are very used to doing the growth assessment for children. But when it comes to the pubertal age, their visits to the hospital also becomes less. So we lose track of it. Oxology and growth monitoring is very very important, because a subtle cut in the centiles cut across, or same centiles persisting indicates a growth retardation. We pick it up. The and about the early onset of puberty. I mean the what to say? Delayed puberty is the other one. The term valarchiye illa is used for everything put together here in India, whether it is undernutrition, whether it's short stature or delayed puberty, and they don't want to talk about puberty. They're very very it's a taboo over here. So it's our duty to make sure when we start off monitoring the growth, and I don't stop it at 8 or 10 or 12, continue and start also doing the sexual maturity rating from the pre-adolescent age group, so we don't miss out on this. Because once hypothyroid is missed and delayed puberty, it's really very very, it's a very late thing. We have to pick it up very early.
Most commonly fixable problem.
Absolutely.
If absolutely, if you check it at the right time.
One more question. If the lady is not diagnosed prior to the pregnancy, she's coming to you. When is the first thing you want to check? Like during the first visit itself, you advise.
That's what I'm saying. First visit, we write the basal investigations, and we tell them to get it within 2 days. Because they may come for a scan later, they may come for the next checkup after 1 month. But I always tell them these tests are very important, because if any abnormality is made within 2 days, first visit. So most of the patients we make out in the first visit see that the damage is less.
Then when you should repeat?
That is start
Every trimester.
No, that is first time you give a dosage necessary depending upon the value. Then check it after
Normal,
1 month.
normal first visit.
Yeah, we still tell that we can repeat it in second, third trimester, but we generally do not do it. But it is advisable to do in second and third, because it may not manifest in the first trimester because of the changes. Second and third trimester it can manifest.
Ramesh, the last question.
எவ்வளோ question தான் கேட்பேன். So the reason you don't see goiter, at least in the Western culture, and now in India and all that, is because of adequate iodinization of salt, milk, eggs.
Is it true?
Yes. If you go to Africa, you'll still see very large goiters. I see patients come from Africa as refugees, some really large goiters. There's no iodinization there.
Thank you, Ramesh Kumar and Prabha. We have traveled with thyroid for the past 1.5 hours. That's been a great exploration about thyroid.